Thank you very much for joining our CST Nursing and Allied Health Professional Education session. We have the honor to have Dr. Karthik Tennankore joining us today. He will be presenting on why does frailty matter for patients waiting for a kidney transplant. By way of introduction, Dr. Tennankore is a professor of medicine at Dalhousie University, a practicing nephrologist at Nova Scotia Health. He currently holds the Kidney Foundation of Canada, CIHR Clinician Investigator Award, and serves as the division head of nephrology. His research focuses on frailty, home dialysis, and improving outcomes for patients with advanced kidney disease. He leads several national studies and has published widely on pre-transplant assessment and post-transplant care. He essentially bridges clinical research and the multidisciplinary practice, so we are very fortunate to have him come today and present on frailty. So over to you, Dr. Tennankore, and thank you for joining us.
Thank you very much, and absolute pleasure to present to you today. Before I dive in, I just want to mention I don't have any disclosures that are relevant to any of the content I'll be presenting today. So I really do have a couple of objectives that I want to get through. And basically, I want to talk to you a little bit about the definition and classification of frailty, something that probably more and more of us have heard of and are experiencing or hearing about assessing patients around frailty, particularly those who are waiting for a kidney transplant. Talk very briefly about frailty impacts health outcomes in this population, and then spend some time talking about a study that is happening in Canada that has pretty much completed recruitment, and we hope to sort of have the analysis done fully this year, and then touch a little bit on, generally speaking, what are some future directions for research? Where do we want to go with this information? I'm trying something a little different. So a lot of the images you're going to see here, I actually did use GPT-4 to generate these images. So we're not necessarily seeing real people, but we're seeing AI generated images. And I have to say, I'm pretty impressed with some of the images that I was able to get. But I want to start just by talking about, the definition of frailty. What exactly are we speaking about? So one of the best definitions I came across is just this one here. So it's a syndrome of low reserve and low ability to resist against stress due to a decline across multiple different body systems that ultimately leaves a person vulnerable to bad health outcomes. And when we think about some of the components of frailty, these were probably best teased out in a large consensus workshop that was done in the geriatric population a number of years ago. And some of the key points, there were 39 different statements that encompassed this entity of frailty, but they included things like it's multi-system. It changes over time. So we expect, typically someone's severity of frailty might change over time. It's not the same thing as disability. So an individual can have a disability, but otherwise be very robust and not be frail. And one can have frailty, but no obvious disability as well. It leads to this notion of vulnerability. So if you took somebody who's frail, they're more vulnerable to poor health outcomes. And a very interesting one, I would argue one that's a bit controversial, is this idea that it could be reversed. There may be a way to change it or at least stabilize it. But it's important to appreciate what frailty is not. And, if you were to sort of put in a Google definition of frailty, you might see something like the condition of being weak and delicate, the sort of increasing frailty of old age. We're not really just talking about an age-related phenomenon, and we'll get into a little bit of that later on. And it's not weakness in character or morals. Now, you may sort of see that statement and kind of laugh a little bit about it, but the reason why it's important to recognize, these things that it's not, is that it's very important to patients. So in a qualitative study, it was shown that participants felt that term frail actually had quite a negative connotation. And it's quite possible because, one's perception of what the word means versus what we're trying to achieve with the word are two very different things. So important to keep this in mind when interacting with patients. So how do we actually measure this entity? Definitions are great, but that doesn't really tell us how to capture it. Well, perhaps the most common tool used to measure frailty is something called the Fried frailty phenotype. Think of this as like an on-off kind of switch. You're either frail or you're not. There are 5 different criteria. They include things like slowness, which is determined by walking speed, weakness, which is determined using a dynamometer to assess grip strength, weight loss based on a question, another question around exhaustion or patient perceived exhaustion, and then a large questionnaire looking at one's activity level. Based on all of this information, if you have any 3 of these criteria, you would be defined as being frail. You might have sometimes seen if you have 1 or 2 criteria, you're pre-frail, but generally speaking, this is sort of a binary measure. You're either frail or you're not. Now, this is one tool. There's a more sophisticated approach called a frailty index. This was generated by Dr. Ken Rockwood in Nova Scotia. A frailty index is where you take 30 or more different types of conditions, usually across multiple domains. So maybe social or cognitive domain, the function domain, mobility, or sort of medical comorbidity. And your frailty index is a ratio of all those different, health deficits that you might have over the total number of deficits in your frailty index, defined by the number of items that you have in there. So for instance, if there were 30 items and say I had 15 of them, my frailty index score would be 0.5. And when you plot frailty indices on a graph, most of the time it kind of looks like this. You get this sort of gamma distribution where as you get to those higher proportions, there tend to be much fewer individuals that are at those higher levels. And this is intuitive. The idea here being as you build all of these deficits, because you're more vulnerable, ultimately individuals with those high scores will pass away, will succumb to mortality. So it would be near impossible to have somebody, with a frailty index score of 1, meaning they have every single deficit in the condition. Still other types of measures to assess frailty. Another one that was identified here at Dalhousie is called the Clinical Frailty Scale, again, developed by Ken Rockwood. This is a little different. It's more of a clinical impression of frailty, a graded impression based largely on function. It's gone through many iterations over time. More recently, one that includes pictorials as well as descriptions and some considerations around cognitive impairment, usually score from 1 to 7, or in this latest iteration, 1 to 8 with another category of 9. We think about this one as being more of a clinical kind of screening tool based on your impression of a patient, maybe based on a number of years of interaction. And it doesn't stop there. In a very recent systematic review, there were 105 studies screened, and of the 90 or more than 90 different frailty assessment tools that exist in the literature, more than 20 of them had been used in some capacity in a kidney disease population. But I showed you those 3 because they're the most common frailty tools that are used, the Fried being far and away the most common, followed by that clinical frailty scale, and then the frailty index. But maybe a more important question is not, what are all these tools, which one should be used, but what are some of the features that make one tool better than the other? So when we think about that Fried phenotype, I think I mentioned to you, it's kind of like an on-off switch. You're frail or you're not. So it's pretty easy to interpret, but the information may be hard to get. You have to have a grip strength measure, a way of assessing walk, time to deliver questionnaires, but it's pretty easy to understand. You're in one bucket or the other. I would argue, though, that it lacks a little bit of what we would sort of call that construct validity, meaning, is that really what frailty is? Is it you're in one group or the other, or is it more of a graded severity? And this is where the frailty index and clinical frailty scale might be a little bit better. So both of these tools, it's more of a score-based or graded severity. Again, data may be hard to get for the frailty index if you're looking at a number of different items across different domains. And I would argue it's still a bit hard to understand the frailty index. Like, you see a patient in clinic and you're talking to them and you're like, oh, your index score is 0.26. Like, they may not quite understand what that means, and it may be hard to sort of operationalize that into care. In context, it's very detailed and very informed. The clinical frailty scale, easy to interpret, more of a sort of graded measure, which is perhaps more real to what frailty actually is. But there is a little bit of a gestalt aspect to it, which might make it a bit more subjective. So I think, each of these tools has their benefits and, their drawbacks. But one thing is for certain, just having an impression based on just a look at a patient and saying, oh, they're frail and they're not, generally is not the right approach. Many studies have shown that that does not agree well with objective measures of frailty. So my usual approach is to say, well, if each of these measures has some value add, why not look at them all together? And I'll show you our study a little bit later on, but that's exactly what we did. This is one figure from that study. And really what this highlights is picking those three big tools, the Freed, the index, and the scale. You can see that each of them is capturing some aspect of frailty, but the overlap, it's pretty small. So you could sort of say, okay, well, maybe I'll measure all three and only sort of count this middle population. Or alternatively, maybe there's valuable information to be gleaned by using a number of different tools all together in a study or in your approach to assessing a patient. So the three big take-home points from this section, there are many different tools. I think each of them addresses a different aspect of frailty. My personal view is that more is probably better, but you have to consider things like burnout, what available resources do you have? And I would just avoid that subjective, uninformed impression where you just look at someone and sort of gauge what you think based on, no criteria or reasoning that hasn't been shown to really associate well with objective tools. Okay, so we have this, entity of frailty. Now we know how to quantify it, but how does it actually associate with one's subsequent health? So I'd start by saying, if you look in the literature, there are a number of studies across the spectrum of kidney disease showing you what the association is between frailty and poor health outcomes. CKD populations, dialysis, and that transplant waiting list time, and then of course after transplant as well. This is one of the earlier applications of the clinical frailty scale, and it was actually done by one of my students back in 2015. Here we took everybody on dialysis. They all had a measure of that clinical frailty scale score done. Now you might appreciate that this only goes from 1 to 7, and that was because it was a slightly older iteration of the CFS. And what you can see here is that with each graded increase in the severity of your frailty, if you look at the red bars, the probability that that individual ultimately, died in follow-up progressively got larger and larger. I think the other really surprising thing, of course, is that the proportion of patients that got transplanted, yes, expectedly got smaller. But what was surprising is that any individual in this study who had that clinical frailty scale score of 6, which is severely or almost very severely frail, none of those patients at any point in time in follow-up actually received a kidney transplant. And that can be for a variety of reasons, just including their poor health in general, or maybe that they actually experienced that outcome of mortality. This association with poor health has also been shown after kidney transplant. Again, this is just one study I'm highlighting. It's one of the earliest studies to look at how the Freed phenotype, that on-off switch of frailty, associates with outcomes after kidney transplant. So this study looked at over 500 individuals who were transplanted and amongst other things looked at its 1, 3, and 5-year health outcomes. You can see that those individuals who are not frail, overall did pretty good, even out to that 5-year mark. In contrast, those that were categorized as frail, and this is after transplant, after actually receiving the organ, had a fairly substantial drop-off in their survival at 5 years. And looking at an adjusted analysis, multivariable adjusted analysis, and said differently, individuals who were frail were twice as likely to die after transplantation. But it's not just about mortality. There are other health outcomes as well. This is the same researcher, Dr. Mara McAdams-DeMarco, who looked at hospitalization. And in particular, her study was focused on the effect of frailty on that outcome of hospitalization after transplant. And so a couple of interesting things from this study. the first thing that you can see is that whether you were younger, in this case using a threshold of 65, or older, your risk of readmission after your incident hospital admission for transplantation was actually the same. So age, numerical age, wasn't actually the big marker. It was frailty status itself. And you can see that that risk was pretty high. And it doesn't stop at hospitalization as well. If we look across the literature, individuals who are categorized as being frail using a number of different tools or approaches in the short term have been shown to have more depressive symptoms, lower quality of life, a prolonged hospital stay after their transplant, and then ultimately delayed graft function as well. In that short and medium term, it's been shown that individuals who are frail are more intolerant of immunosuppressive medications, in other words, more likely to develop leukopenia and potentially infectious complications. And it's also been shown that there's an association with cognitive impairment in that medium term after transplant. So, I could probably do a whole separate talk on outcomes after transplant, but I think what I often hear is a little bit of that so what factor. And the first thing I'll hear often is, frailty is just getting old. Like, I can tell you that anybody who's older is going to be at risk of these outcomes too. My argument is that frailty is highly prevalent even in young patients. And it's been shown that age doesn't actually modify how frailty impacts outcomes. So if you're young and frail compared to people who are young and not frail, you're at just as high risk of experiencing certain poor health outcomes than given the same scenario if you're older in terms of your chronological age. I do often hear that frailty is just the same thing as comorbidity. If you have diabetes, it's kind of the same, or heart disease. And that's not true. Time and time again, we've seen that you can be frail and have very few sort of health comorbid conditions, but it might be other aspects of this entity of frailty that are impacted. And then I've heard, of course, that healthcare providers don't need tools. We just know, we hear that a lot. And I think I've already touched on this, but several studies, including one done in dialysis, showed that that gestalt, only about half of the people that had the gestalt that someone was frail were correct when looking at an objective tool. So I think we have to sort of shy away from, uninformed views about whether a patient is frail or not. So big take home from this section, we know that frailty impacts health outcomes after kidney transplant. This occurs with or without other health conditions and irrespective of age, which brings me to that question, is there a population that we're missing? So, I've characterized this poor health stuff in dialysis, characterized it in transplantation. But what about those who are actually waiting for transplant? So that subset of individuals who might be active on the kidney transplant waitlist in this case, or even other organ transplant waitlists, where they're a little bit healthier maybe than their other dialysis counterparts, but are not yet at the point where they've received that transplant. So this has been explored, again, in a number of different studies. I go back to Dr. McAdams DeMarco, who looked at a large cohort of individuals in the United States who were dialysis candidates and waitlisted for a kidney transplant. Again, it was the Fried phenotype that was used to characterize frailty. And of the just under 2,000 patients, about 18% were frail and 207 didn't survive to transplant. And once again, if you look at that waitlist population, those who were frail were twice as likely to either die or sort of get removed off the waitlist before getting that kidney. So again, we're seeing that even in those who are selected, who meet the criteria to be waitlisted, they're at a twofold higher risk of dying before getting a kidney while waiting for a transplant. But I think it's important to appreciate that Canada is not the US. I think that statement has more weight now than perhaps ever before based on what we're seeing. But what I'm referring to is that individuals on dialysis and after transplant have been shown to live longer in Canada for a variety of different reasons. Outcomes are better. Individuals on the waiting list tend to live longer if that waiting list is occurring here in Canada as opposed to the United States. And why I bring all this up is because the majority of studies thus far have been based in the United States. I will say that there's a Dr. Singer out of Toronto, who's a large area of focus is on lung transplant recipients, who is doing and has had a multi-center study looking at frailty. And I believe there's a kidney transplant population there as well. But other than that and a few others, the majority of research up to now has been based in the United States. So that brings me to a study that I've been talking about now for at least 8 years in a variety of different ways, and that's finally finished recruitment and is going to be entering that kind of important analytic phase. So this was a study that occurred in Canada where we specifically were focusing on those who were listed for a kidney transplant across a number of different sites. So you can see we had pretty good provincial representation: Halifax, New Brunswick, Ontario, Quebec, and Saskatchewan as well. In this particular study, we did a number of different frailty assessments, and really the three ones that we focused on the most were the Fried frailty phenotype, which I talked about. We developed a frailty index, which I'll show you what was entailed in that. And then we also had the clinical frailty scale as well. So the objectives of this study, which hopefully will be finalized soon, is ultimately to determine how frailty impacts survival or withdrawal from the waitlist prior to receiving a transplant. But we do have some secondary outcomes of importance, including hospitalization. We have a measure looking at quality of life. And then we're also interested in how frailty changes amongst those who are actually on the waitlist. So I mentioned this, but we created a waitlist specific frailty index. It's important when you do a frailty index that it's relevant to the population that you're studying. What I mean by that is if you're going to create a frailty index for a kidney transplant population or a waitlist population, you probably wouldn't have kidney disease as one of the items because everybody in your population would have it. So what we ultimately did do is we wanted to look at a number of different domains. So we had some items that focused on that social or cognitive domain. I've just listed a couple here, but this wasn't an exhaustive list. If you look at that picture in the upper right corner, you can see all the different things that were involved. We had some domains sort of in the area of function, mobility, and then some in the area of medical health deficits. Overall, this frailty index had 38 different items, and we captured this on each of the individuals that were enrolled in this study. Now, what did we find? So as I mentioned, this study is going to be completed this year. So you're just seeing an older snapshot where we kind of looked sort of at an interim point just to get an idea of prevalence and a few outcomes. So 2020, kind of the pandemic time, we did do this small analysis where we looked at about 540 patients with a mean age of 54 years, of whom 36% were female. You can see that most of these individuals were receiving hemodialysis and smaller proportions on peritoneal dialysis or preemptive. Overall, we found that 16% of this population were frail using the Fried phenotype. This is very much consistent with what is sort of seen in the United States. But it's important to see that there were a few differences across different characteristics. So those that were older, if you look at the kind of red bars, tended to be more frail, so higher prevalence. Those that had a slightly longer dialysis vintage, in this case more than a year, tended to be more frail. And there were similar proportions of people who were frail receiving either hemodialysis or PD, but a smaller proportion that were preemptive. What about some of the other frailty tools? Because I mentioned we did more than the Fried. A larger proportion were frail when looking at that frailty index approach, but you can see the sort of graph of the frailty index is very similar to what you'd expect. And similarly, using a threshold of 4 or more for that clinical frailty scale, the proportions were kind of along the same lines as that Fried phenotype as well. And again, this was just our first kind of look, so more data will come. But the big take home from this is you can see with sort of mortality risk or hazards on this axis here and different measures of frailty on the y-axis, the risk of either dying or being withdrawn prior to getting a transplant was a little under 2-fold higher for people who are frail. And that's whether you use that Fried phenotype, not statistically significant, but smaller numbers, frailty index approach, a frailty index approach with some measures removed, or that clinical frailty scale. And again, said differently, kind of same messaging, those who are frail were twice as likely to die or get taken off the wait list because of a permanent illness before getting to the point of getting a kidney transplant. So to summarize this section, frailty does impact health outcomes for waitlisted patients. This is with or without other health conditions and irrespective of age. So of course, the big kind of question, is frailty actually a contraindication to transplant? Should we be measuring frailty? And then if people meet the criteria, maybe they shouldn't be eligible for transplantation. Well, I guess the better question is, how do we actually use this information in decision making? And the first thing I want to point out is that, we don't actually routinely capture frailty in our patient population. I think I touched on the fact that a lot of people are able to provide what their clinical impression is, but the routine measurement of frailty is not something that is incorporated in a robust way into guidelines or approaches. You'll see there's variable ways that it's done from center to center, but it's not consistent. And this was a review paper that we put together emphasizing that we're probably missing an opportunity to capture this entity of frailty, not just in the waitlist population, but across the spectrum of kidney disease. And I would argue, if you see someone in clinic, you should probably screen everybody for this entity of frailty. And then there are certain key points, certainly transitions in care where you might want to repeat that screening. So at dialysis initiation, maybe at certain visits in the kidney clinic or home dialysis unit, after a major health event. And I do firmly believe that frailty should be measured as part of the workup for a kidney transplant on a routine basis. And, has there been any evaluations to sort of look at how this might impact decision-making? Well, in another study done out of the US, looking at 132 transplant centers, they found that centers that always assessed frailty as part of that wait list tended to have lower rates of transplantation. I put that in red because, generally speaking, that's not something that we want to be happy about. But on the flip side, they also tended to have a lower risk of death before transplant, and this likely represents selection. And then they also had better outcomes after transplant, so a 30% improvement in graft survival. So the argument here is that, yes, if you capture frailty, you may sort of, either delist people sooner, or maybe it's possible you're not listing as many people, but your outcomes might be better. So I'd argue there's some good, but some bad with that as well. But the question is there actually a tipping point? So is there a threshold of frailty where you would say, okay, after this level, I probably would not want to transplant an individual? It's important to conceptualize, well, why? Well, there may be a scenario where transplanting somebody, that person might be at too high risk, maybe with the operative procedure itself, or potentially with, the risks with immunosuppression, which I highlighted is something that's real that we do see post-transplant. The other issue is there may be a threshold of frailty where the chance of experiencing benefit might be too low. This was a study done by one of my close colleagues, Dr. Kyberd, where he looked at different contraindications to transplant and then extrapolated what the probability is that those individuals would actually get some net benefit from a transplant. And as expected, conditions that we know are generally contraindications to transplant, things like dementia, multisystem disease, or active cancer, the probability of getting benefit was very low, too low that these are expected contraindications to transplant. So what's interesting is that severe frailty, because it does have that strong association with poor health outcomes, it would actually fall into a similar range as these conditions. So again, we're back to this question, okay, well, is severe frailty a contraindication? But this is where things change a little bit. And that is that we know that frailty actually changes over time. If you remember very early on, I talked about the idea that frailty is dynamic and can change, and that it might even be able to be reversed. And this is pretty interesting, but it was a study done, and I'm hoping we can replicate this in our study, by Dr. McAdams DeMarco. And she looked at the proportion of individuals who were frail at the time of transplant. And if you look at these darker bars right here, you can see that 1 month after transplant, a higher proportion of people were frail. This kind of makes sense because maybe you're on dialysis, you've just had a major surgery, expectedly you might have a function drop. But then by about 2 months, people started to improve. And by about 3 months after kidney transplant, the proportion of people who were frail was actually lower than the proportion at the time of transplant. In other words, in that first month, it looks like more people get more frail, but by about the 3rd month, you're starting to see improvements in frailty severity. And I've often thought that transplant's one of the very few kind of natural experiments we have where you might be able to actually reverse frailty by restoring biologic function with a kidney organ. So this idea that frailty can change over time emphasizes to me that a one-time measure of frailty probably is not a contraindication to transplant. And so that brings me to the key take-home points from this section. Yes, it's associated with poor health outcomes. Yes, we know that the routine capture of frailty may lead to better health outcomes for a variety of reasons. I do believe that we should be measuring this as part of our workup. But I don't feel that we should deny people access to transplant just because they have one single measure of frailty severity that shows that they are frail. And in fact, I would argue that there could be a subset here, those that are getting progressively worse, that might be important. But I think in general, changes over time are more important than one-time measures. So a lot of this is around practitioner perspectives, but we always want to be sure to include the patient voice anytime we're thinking about, something new that we may want to introduce. So what do patients think about frailty? Well, the literature supports that we should be measuring it. In a survey of patients that was done back in 2018, 29 participants, the majority of whom were older, patients felt that there was a bit of a psychological component to frailty, and some of them were a bit skeptical of this syndrome that exists where there aren't a lot of other health deficits. You can understand that, if you're a patient and you don't have a lot of health problems or comorbid conditions, and someone says, well, based on the data, you're frail, you might be a little bit skeptical of that. But ultimately, when presented with what this entity is and what it means, in general, patients who are frail wanted to know, okay, well, you've told me that I'm frail. What can I do to treat this, prevent it? How can you help me kind of overcome this entity? And that brings me to the very last part of the talk, which is really, how can we actually intervene to help those who are frail? So, we've identified this entity. We know it's something that we need to, capture, evaluate, measure. We have some idea that's associated with bad health outcomes. Is there anything we can do to reverse this other than, considering transplant and that kind of natural experiment idea that I was talking about? Well, one of the strategies that is being explored a lot is something called prehabilitation, which is the idea of improving one's functional status or functional capability before they undergo surgery. Prehabilitation has been looked at in a variety of different ways, ischemic preconditioning, different types of things like this. But what about specific to frailty? Well, this was a study that was done in the US where they took 190 active transplant candidates and then enrolled ultimately 24, of whom 18 participated in a prehabilitation program. You can see a huge drop-off in numbers. The tough part with any interventional study is it's easy to come up with a good idea, but it's hard to actually get people enrolled in the trial. But about 31% of these individuals met that criteria for frailty. They were then enrolled in a prehabilitation type program. I just showed you a couple pictures here. The prehabilitation focused on things like, balance, coordination training, some sort of stress mindfulness training, cardiovascular work, etc. And ultimately what they found is that participants in this prehabilitation program were very satisfied with it. A pretty big increase in physical activity, so more of them were more likely to be active. Anecdotally, a shorter length of hospital stay after transplant, but this was hard. By the time they got to the point of looking at hospital length of stay, only 5 people had actually made it to the point of transplant, so very small numbers. But nonetheless, a signal here to suggest that we might be able to intervene on a vulnerable population and improve their health so they do better once they get, in this case, that kidney organ. And this is where the data gap is probably the largest. There are lots of studies that look like they're upcoming. I try to check at clinicaltrials.gov to see if any of these have been published, but studies looking at exercise and chronic kidney disease, different types of interventions for older adults with kidney disease, and then some upcoming trials focused specifically on frailty and a waitlist population. One that I'm very excited about that is still not published, but probably nearing completion is the Frail-MAR study. In this study, it's a sort of a multimodal rehabilitation intervention where they're looking at not just physical function, but also nutrition and also psychological health as well. And then another one that I've listed there. So really, these upcoming trials, I think appropriately are designed to modify frailty in an effort to ultimately improve downstream health outcomes, but we're not quite at the point where, a clear intervention has been developed to address this sort of entity of frailty. So we're just kind of on the tip of the iceberg when it comes to intervention. So I kept it short so we can have some time for questions, but ultimately, in this talk, hopefully I showed you a little bit of the data suggesting that frailty is very prevalent amongst transplant candidates. Again, here focused on kidney transplant, that it can be measured in a variety of different ways. We know it's associated with bad health outcomes. But I think that while it has these associations, to me, it's not a permanent contraindication. There may be a threshold where it is, but I would emphasize that dynamic frailty might be more important. Someone who's getting worse, maybe that is the population that's at most risk. And I think this idea of coming up with interventions or strategies to sort of prehabilitate patients, this is, I think, where the interest, certainly for most people, probably lies. But with the barriers of recruitment and trying to develop these types of interventions, it may still be a while before we see something, that's really shown to be beneficial for patients. Here are some of my references, and I'm happy to take any questions.
Okay, does anyone, thank you very much for that. That was a very exhaustive discussion on frailty and kidney transplantation. It's nice to see that we're considering different interventions and strategies when we identify patients that are frail. And then maybe all of us who are online can start thinking about a multi-center trial to see if the intervention. It was nice to see the strategy, including nutrition, having a nutrition background. It's nice to see that, in my opinion, you really can't do physical activity without making sure they're getting adequate nutrition. But I think that this was a very exhaustive discussion on frailty that I think we all needed. So I will stop there and ask if anyone has any questions. So Bryce.
Can people hear me?
Yeah.
Hey,
Thank you,
Bryce.
Karthik. That was wonderful. One of your colleagues who lives close to you would probably ask the question. I may have missed it. Were there any gender or sex differences in the incidence of frailty, and had that already limited the number of people that entered in your study?
Yes. So in our study, when I did that analysis, we had about 40% of people who were women and 60% men. That's sort of the 2020 recruitment. We recruited more people since then. I don't think I would say that that I actually clarify that. I don't think I have a great idea to know if sex, I don't think we captured gender in a detailed fashion, but if sex impacted enrollment in the study. But what I do know, which I think is kind of very interesting, and my colleague Amanda is going to be exploring this and some additional research that's happening soon as well, is that it looked like the clinical frailty scale, which is not sort of like a gestalt impression, it should be an informed subjective impression, but it did look like more people using the clinical frailty scale categorized women as being frail. So there is a tendency based on that sort of subjective impression to categorize women as being frail. But the clinical frailty scale had less sort of, diagnostic utility in female patients. So what that does tell me is that if we just rely on subjective tools, we may be over categorizing women as being frail who are otherwise not frail. And that might have some implications for, things like delisting or even listing in the first place. So I think we have to be very careful about that. And I do think, while I like the clinical frailty scale and in its simplicity and its ease of administration, I do think there is value in having objective measures and potentially also having, thresholds to define frailty that might vary between men and women, especially if you're going to use, certain types of tools and measures that may be more favorable to a population of men versus women. So I think that it brings up a lot of points. I think the subjectivity thing is a big issue. And I will say that I know that Amanda is going to be doing more research, both with this existing study, but also looking at, perceptions of frailty, measured frailty, subjective, objective, across all populations in, both dialysis and post-transplant as well.
Thank you.
Anybody else have any questions? So I'm going to ask another question if that's all right.
Sure.
So moving forward, how do you see all of us as part of the allied health profession helping to identify, treat, intervene in terms of identifying patients with frailty?
Yeah, so when I look at frailty, I think identification to me should not just be identification done by physicians. Certainly things like objective measurements, quantification scales, even subjective impressions that are guided by something like the clinical frailty scale. There's no reason why all of us as healthcare practitioners don't have the skill set or tools to be able to do that with our population. And if we're thinking that capturing frailty is going to be a bit of a burdensome initiative, it's going to require lots of human resources, then we should open it up to all of us to be able to measure it. And if we work well as part of a team, interact with each other to talk about what those scales or graded values mean. So I think that's one phase of it. The intervention phase, though, is where I view multidisciplinary care is going to have the most impact. So, you talked a little bit about, you're happy that there's maybe nutrition assessed in one of these interventions. To me, it's shocking to think that you would quantify frailty and have one of your measures be, are you losing weight unintentionally? How much? But then all the interventions are focused on physical activity, So to your point, if we're thinking that this entity of frailty is across multiple different domains of health, then we need experts who are, poised to help us develop the best interventions in each of those domains. So if I was going to come up with something for frailty, I would want someone who's an expert in that kind of social, cognitive, societal, interactive domain as I was sort of thinking a little bit about it. And on the multidisciplinary care team, if I think about transplant, even just locally, our social workers are critical in that regard. We have psychologists who work with patients to sort of help, stabilize like the psychology of transplant, even around things like medication adherence, doing cognitive testing in patients, that day-to-day interaction with the nursing staff. Like you can see, I've named like 3 different groups just off the top of my head who would all be critical in developing the right intervention. If it's a nutritional one, obviously getting, you know, a robust team of dietitians involved. We know in dialysis, we spend a lot of attention to the right type of nutrition that our patients need. Turning that into the right type of intervention would be important. Polypharmacy is critical because we often prescribe lots of medications. All those medications have probably some negative impact on a patient. So it's a perfect opportunity for pharmacy to be involved to help us like optimize medications, think about ways to reduce pill burden. And then of course, like even comorbid health conditions and things like this are where, you know, the nursing physician side are going to come in as well. So, I mean, for me, having that like big, broad team to develop the right intervention makes the most sense. But it's hard to do that. You need to get a bunch of people sitting around a table having a proper conversation about designing the right intervention, then testing it. You also need patience at that table because you can come up with all kinds of things until you're blue in the face. But if the patient's like, I can't do this, then you instantly don't have an intervention that's going to help that population. So there's an opportunity here. I without naming names, because I'm not sure if it's kind of like embargoed right now. I do know that there's an investigator in Toronto who is working on just this type of multidisciplinary intervention. Really hoping that said individual can get funded one day because it looked like they were really on the right track, kind of addressing each of these key domains.
Okay, thank you for that. Any other questions? All right, I'm gonna make another comment.
Sure, yeah.
I really like your discussion about pre-transplant really early on, even in the dialysis population, assessing frailty, right? Because I think that if we can kind of intervene early on and prevent the progression of frailty, I think we will be further ahead. It's kind of like we're at the end of the process and we're making the assessment, and you know, there's a time frame between when they're assessed and transplanted. So I like the idea of thinking about, you know, assessing the frailty much earlier on, and maybe we need to think about that. Certainly colleagues, RDs that work in the dialysis units, maybe we need to start incorporating the one of those tools and see what we're finding.
It's a great point. I mean, we're close to finalizing a sort of retrospective look back where in our dialysis facility here, we do that clinical frailty scale in everybody who starts on dialysis. And we keep seeing that same signal. Like if your frailty scale score is 6 or higher, you don't get to the point where you get a transplant. And some of those patients that are 6 or higher don't have any other reason why they couldn't, you know, potentially get a transplant. I just think that their health is vulnerable. And then some of those individuals, it just deteriorates quickly over time. So that brings up the idea, okay, capturing it earlier, but then going one step back. And, you know, I often think nowadays we're starting to, you know, stretch a little bit and take more people preemptively, maybe targeting certain populations for, you know, potentially higher risk donor organs, but appreciating that the benefit of getting that transplant outweighs the risks of remaining on dialysis. So if I was going to get creative with strategies, I might think about, you know, using that information and trying to say, okay, well, now how can we look before dialysis even starts? Maybe there's a population of adults who are frail who should be prioritized for, you know, receiving kidney, one that maybe wouldn't be a kidney that you might necessarily give to somebody who's very, very young or something like that, or very healthy, very non-frail, but that you know that if that older adult gets the kidney and avoids the experience on dialysis, their health might be better. So I do agree. I think, you know, if we had been capturing this across all the sort of spectrum of kidney disease for a long time, we might have been able to do that now. But now we're starting to keep taking that step back and say, let's measure it earlier and earlier and earlier so we can actually impact that decision making.
Okay, thank you. Any other questions? We still have a few minutes left.
I have a question or a comment. So we have a potential living donor recipient coming up for later this summer. And so I started to ask her today, so what are you doing for exercise? How are you walking? I'm trying to think of a way to keep her in as good a condition as possible. And she says, well, I need to get a cortisone injection in my spine because I can't stand for more than 15 minutes before my legs get weak. And I'm thinking, okay, there's your frailty coming through. And after transplant and surgery, she's going to just be a mess unless we can deal with her spine. So it's going to help maybe to get that looked at in the workup phase and when they're doing the last minute plans for the surgery. And I'm not sure she really told anybody about that on this side of it because it's not related to her dialysis at all.
Right. Yeah, and it's interesting because like that in of itself, you wouldn't view as being a reason why, you know, you'd slow down that process for transplanting somebody, but it's very clear that that's going to probably have some impact, or very well could have some impact in that kind of post-recovery phase.
Mhm.
I mean, I think in these scenarios, like it's always a bit of a balancing act because, you know, generally speaking, especially in someone who's got the opportunity to sort of get a live donor kidney transplant, delaying things on dialysis is never a good thing, right? Because that longer dialysis exposure puts them at more risk. So you never want to be in a situation where, you know, maybe because of the time it might take to get a cortisone injection or something like that, you're going to delay the transplant decision under the idea that they'll be more mobile after transplant. You wouldn't want to do that. But I think it does point that there's probably a lot of these, you know, these factors that when they sort of are cumulatively added on top of another, they will have an impact on somebody after transplant. And I think it's what you're doing right now, recognizing them early, seeing how much of this can we address. I mean, this is an N of one, you know, one critical sort of scenario, but doing what you can, but then also not necessarily sort of denying that access. And if it did get to the point that the person's mobility is not going to get obviously better by transplant, making sure soon after transplant that mobility issue is still addressed when safe to do so, you know? So, I mean, it is getting the mind thinking a little bit differently around these points, you know, identifying a mobility problem is kind of a big thing. Even if it's not like the heart, right? That's the reason why or something like that. But yeah, excellent thought and discussion about that.